Masterclass number 2. The amount of people who registered for this one either means one of two things. Either I did a great job on the first one, which I don't think is the reality. I think everyone wants to see you. So I
Yeah.
don't know what it is that you've done to be so popular, but I'm setting you up for a lot of expectations today.
Yeah. Big expectations. Could be good or bad. Hopefully I don't get booed off the stage here, right?
Well, I mean, so you've written a book recently, you formulated a few supplements, you're running a successful practice. I think you're good. I think
I
I
think I'll
think
be
you
able to
can
handle
rise
it.
to the occasion.
I'll do my best.
You
Do my
have
best.
enough adrenal reserve to rise to this occasion. So
I
that'll be
actually,
awesome.
I just had a US Enzymes protein shake
Ah,
right before this because I just got done. I got in a quick workout, little post workout follow up, and now I'm ready to go.
nice. I did the same thing, a little zone 2 to get my brain on point. I love it. So, Dr. Eric, you're very well known within the Master Supplements US Enzymes community, but for those people who don't know you, I usually like to, start off with having the guest tell a little bit of their story. Let everyone get to know who they are and how they came to be where they are today.
Well, I think came from like simple beginnings, right? Like in the beginning, I had no intention to be in healthcare, none. So when I was young, I didn't know what to do. I just wanted to get out of the house. I had, didn't really have the greatest upbringing, so I just wanted to get away. And I got off to college, I was going to be a business major, and I thought this is what I want to be. I just want to be away from home. And I got injured my freshman summer after my freshman year of college, and I wasn't gonna be able to go back and wrestle because I was in rehab and my back was killing me. I couldn't get better. And I eventually met a chiropractor at a local restaurant where I was kind of hanging out. I just transferred. I was working in a hospital, transferred to Kutztown University from Gettysburg University. And I just wanted to get back into school, take some classes. And what's funny was when I went to take classes, the person who was helping me schedule there was no business classes because it's mid-year, nothing's available. And I said, hey, what major does nobody take? And she said, medical technology. I'm like, perfect. That's my major. And she said, do you know what it is? I said, I do not, but are the classes available? She said, yeah, nobody takes those classes. I'm like, then I'll take them. And so I was in this kind of working in a hospital, working in the OR, ER, and I'm doing this medical technology thing. And I'm like, all right, this is okay. And in the meantime, I meet this chiropractor and he says, hey, you should come play rugby for us. Cause I had a rugby jacket on and I said, listen, I can barely walk. I can't play rugby. And he said, hey, I'll make you a deal. If I can get you better, you got to play rugby for us. If I can't get you better, you don't owe me anything. And I'm like, all right, well, who are you? He's like, I'm Doc Jones. I'm a local chiropractor. I'm like, man, the witch doctor. And he's a big dude and he could have squashed me, but, I gave him a chance, and within a few months, I was back playing rugby again. And so I got adjusted. This thing I had always heard was this crazy lunatic, throw chicken bones people. This guy changed my life. And at the end of 3 years playing rugby, and I was getting ready to graduate, and because I'd been working in the hospital, then I was like, I guess I'll go to med school. I mean, I don't know what else to do at this point. I was stayed in the major. And he said, hey, I think you should go to chiropractic school. And I said, well, why would I do that? And he said, hey, because this can help your health. And he gave me about 5 books and said, read them. And as I read the books and I learned about the chiropractic philosophy, and then I looked at my own health, and my sinus problems were gone, my gut problems were gone, all these health problems I had as I thought were normal things growing up. I was like, wow, they all got better. And I didn't understand why. He said, why do you think? And I was like, I don't know, clean living. But, it wasn't clean living. I'm going to school full time. I'm working full time, playing rugby, drinking like a fish, eating terrible.
College kid, yeah.
College
They
kids.
live a little bit of a less clean lifestyle, maybe.
Yeah. And somehow still got better. And so I went off to chiropractic school, did that thing, came back, and was just doing good old chiropractic and having a great time. And then my brother reached out to me one day and said, hey, my wife has got diagnosed with hypothyroidism. She's got fibroids. They're going to do a total hysterectomy, and she's got anemia, and they're going to put her on iron. I'm like, that sucks, but what do you want me to do? And he's like, I want you to figure it out. I'm like, it's not really like what I do. And he goes, I know, but you'll figure it out. And so that started me back kind of into my roots and going it back into the blood chemistry and trying to figure that out. And then I was like, all right, what is this? This is like maybe an autoimmune issue. And her medical doctors were saying, no, that's not it. So I really started digging into chemistry, found Datis Karazian, and really started doing a lot of work under him and learn from his stuff. And as I did that, I started learning about thyroid physiology and starting to talk to my clients. And I started asking everybody, telling, when you're in there, you're talking about something, you're talking about what you're learning. And I realized how many of the clients had thyroid issues. And I'm like, wait, are you feeling better? And they're like, not really. My doctor says I'm better, but I'm still overweight. I'm still tired, still fatigued. So then I started saying, hey, well, I was able to help some other people. Maybe there's some things I could do to help you. And that kind of started me really deeper into functional medicine and working with a lot of people through the lens of thyroid physiology. Fast forward about 10 years, I meet, genetics is, probably 10, 15 years. Everybody's getting into genomics, right? Like SNPs and all this stuff. So somebody brought me in their MTHFR thing and they said, I've got MTHFR in this. And they said, can you tell me about this? I said, absolutely I can, but it's going to take a little bit of time. So let's reschedule and we'll go into that on the next appointment. And I quickly started
researching MTHFR.
I didn't know what was going on. And so I started digging into that and I started diving deep and I looked at the 3 people that were really doing a lot of education on the polymorphisms, and Ben Lynch was the guy I kind of really resonated with. So I got some of his stuff and then started sending him questions. And then because I was so inquisitive and asking different questions, he's like, where are you getting these questions from? We became friends. And I started working with Ben for a bit. And then he sent me a paper because the whole time I'm working with people, things aren't quite going the way we learned, in Datis's class and at these courses and functional med courses, because you give people stuff and it should work on paper, but the protocols didn't work. Like, here's the gut protocol and you do it and it would help a little bit and then it get worse, and you do some, work this thyroid protocol and it would seem like it helped, but didn't, but it never seemed like it really worked for the really sick people as well as it should. Healthy sick people, right? Just clean up their diet. They get better pretty quick. But the really not doing well patients, I didn't really get it. And I had done a couple of presentations for Ben, and he passed me a paper one day by a guy named Robert Navio on the cell danger response. And when I read that paper, man, that changed everything for me.
That paper blew my reality open because I finally thought someone has found a pattern that underpins everything of dysfunction. And I remember being enamored with that, just entirely blown away.
And and when you read that paper, you look at why things, it totally makes sense. And so I read that paper. I've read it probably 20 times. I try and read it once a year. Every time I read it, I get something out of it. But that changed the way I thought about thyroid physiology. It changed the way I looked at labs and interpreted labs and thought about what's going on. And then that led to the book, The Thyroid Debacle, that Dr. Kelly Halderman and I just came out with, because when you look at the physiology from that cell danger perspective, it changes how we might think about addressing somebody's health and well-being, because we have to ask the question, is this a person who's in homeostasis, or is this a person in allostasis? Is what's going on broken physiology, or is it adaptive physiology? And I think too often, especially in allopathic medicine, we often think that everybody's in homeostasis. A lot of times in functional medicine, we do that. We just assume that they're operating the same. And so if we give them something, it's going to do what we want it to do. And often it often doesn't. And then we're confused or perplexed as to why. So, over the time, in the last 10 years or so, I've really kind of changed my thinking about things. And I think that's helped me evolve, looking through this lens of the cell danger response. And that's what I've done, a bunch of discussions and talks in conjunction with Master Supplements, different seminars and other venues on looking at specifically thyroid physiology through the lens of the cell danger response. But even though I talk about thyroid physiology, I never really do anything to change thyroid physiology, like aggressively change it. But I use the lens of thyroid physiology to kind of look at somebody and make a decision. Okay, where are we at? What do we need to do? And how do we help somebody?
Oh, beautifully said. And I have two things that I want to kind of dive into from that. The first thing is a selfish request. I'd like a signed copy of the book. I haven't gotten one yet. So, we need to make that happen.
Sure.
But that's besides the point. The second thing is, so when you're looking at all these concepts, right, you're looking at the CDR, it's a concept with a bunch of variables in it. You're looking at thyroid physiology, which has an impetus of understanding about what's happening with that person, but you need a global, I guess, identification system, and that's where blood labs come in for you, right?
Yeah.
So how would you approach understanding the most purposeful use of a biochemistry blood lab?
Well, I think what we have to do is we want to get initially when we want to look at somebody's health, we need a broad panel so we can get a 30,000 foot view. That's my opinion, right? And I think it's probably your opinion as well.
I agree with you.
And what's happened in allopathic medicine, and I came from that world, is that they keep narrowing the panels down. So 30 years ago when I worked in the hospital and drew the blood and did the studies, we had pretty broad panels. I mean, there were probably 25, 30, 40 tests on the initial panels 30 years ago. But now if you get a comprehensive metabolic panel, it could be 14 markers, right? And that's it, if that. And so then the less you see, the less you can manage. So what gets measured gets managed. So if you don't measure it, you don't have to manage it, which is really kind of what happens in allopathic medicine. Is you got a third party who's dictating it. But to me, I think the starting point with somebody is the first thing I want to look at is a comprehensive blood chemistry panel. Mine's about 69 tests and urinalysis. And so I'm looking at blood sugar markers. I'm looking at magnesium markers. I'm looking at a full lipid panel, full thyroid panel, a bunch of inflammatory markers. I want to look at bilirubin. I want to look at, fasting insulin. I want to look at both vitamin Ds. I want to see what's going on there. So I want to take a really broad look at that so I can get a 30,000 foot view of what's going on. And I need to, we have to look at that blood work in context, which often I don't think happens. Is we have to take it into context with what's their health history, what's their signs and symptoms, what supplements are they on, because that can influence the lab. What medications are they on, because that can influence the lab. So we have to look at everything in context. So to me, the starting point with everybody is get their health history, get their signs and symptoms, get their medications or supplements, and now let me take a look at their comprehensive blood chemistry. And I'll do that first before I look at anything else, because I want to see where they're at and what I can tell from that. And then there's things that I think, key considerations that I think we need to take, that everybody needs to consider when they're looking at that panel. But I'll let you, if you have a question you want to.
Well, I'd like to dig into that a little bit more, because I find a lot of people, when they run a blood panel, they use that as their only basis to make a decision. And if you have, a half truth leads to a full lie, is the old saying. Mm-hmm. So when digging into some of these markers, what are some of the organized groups and some of the patterns that you always look for? Because I know that's a big question that a lot of people have with continuing education. You can run a lab test and you can gather a ton of data, but if you don't know what to do with that data, it's really not all that useful. It can actually be a little bit more confusing. So I'd love to dig into that a little bit more.
Yeah. So I guess the first step, like, what are the key considerations? I'd say one, when we're looking at the labs, before we even kind of go to patterns, we want to make sure that we understand that there's lab reference ranges and there's what we might consider optimal ranges. And the problem with optimal ranges is they're not specific. Like if in regard to thyroid hormone, people say, well, the optimal range is 1.0 to 2.0. I don't know that. Maybe, given what? So the lab reference range is 95%, 97.5% of the tested population, right? So that's not and I think that we're talking to the choir here, that's not a healthy level. That's just the average, right? It's 2 standard deviations away. That's the disease range. So if we look at grades, that's the failure range. That's when we need surgery. That's when we need a drug. But that doesn't mean that the person's healthy. Just like a D- doesn't mean you got a great grade on your math test, right? We want somebody in the optimal range.
At least a D+.
Right. We already talked about what gets measured, gets managed. And I think a third thing is that the lab value, I often hear people say, hey, well, their calcium's high or their vitamin D's low, so I need to give vitamin D. The lab value is not the problem in most situations. The lab value is the indicator of the problem. So if we have high calcium or low calcium, we need, instead of saying, oh, I just need to give calcium, we need to take a step back and say, why is this happening, right? Why would calcium be low? Is it because it's not being absorbed? Is it because it's going into the cells and tissues and creating oxidative stress and creating a problem? Because if that's the case, why would we want to give more calcium in that situation, right? So that's important. I think the fourth thing before we get into the patterns is really making sure that we understand the 4 possibilities when we look at a lab value. Right? A lab value could be normal and appropriate, right? I feel awesome. My values are in the lab range, the optimal range, probably appropriate, right? A lab value could be normal, but totally inappropriate given my patient's signs and symptoms, right? So if my patient's tired, fatigued, the excess body weight, their hair's thinning, they look like a hypothyroid patient, but TSH is like functionally low or towards the lab low level. I often have patients say, hey, my doctor said that my thyroid's fine. I'm actually a little bit more hyperthyroid because it's below 1. You're like, yeah, but did they look at you, right? Did they read your signs and symptoms? Because it might be normal, but it's inappropriate for you. And that's what we have to keep in mind, because lab values can be skewed by a bunch of things. Lab values could be abnormal and totally appropriate. So the patient's we'll use thyroid again. If the patient's tired, fatigued, gaining weight, constipated, no libido, and their TSH is elevated, it's abnormal, but it's totally appropriate. I got a person who's probably got a thyroid issue here. Now I've got 2 choices, right? Should I suppress the TSH with a medication, or should I ask why this is happening? Then the fourth part is the lab value abnormal and totally inappropriate, right? One of your hockey guys comes in, says, hey, I feel fantastic. You run this high sensitivity CRP and it's 45. Like,
that's a problem.
That's a problem.
That's a problem. But that dovetails into a really good question, because a lot of people run a lab and they take all the data and then they start making a decision process. How much of it could be just an outlier of something that's actually going on at that moment in time? And when do you think about running a follow-up to start saying, I'm not going to compare this person to the numbers. I'm going to compare this person to the person to get an understanding of what their normal may be. How much of a factor does that play in the decision-making process?
Well, I think it plays a huge role, right? If you had that person come in with a high sensitivity CRP, you go, okay, what else is abnormal here? Is anything else abnormal here? Maybe I need to rerun this again. Did you work out yesterday? What happened in the days leading up to this, right? So ask better questions and then let's rerun it again. But in situations where if that came back again really high like that, yeah, then I'd be like, let's be looking for something pathologic here, right? And in my 27, 28 years, definitely had those situations where somebody said, oh, I'm really healthy. I just want you to tell me what I can tweak a little bit. And you get one of those. And unfortunately, the person finds out, hey, I've got cancer. And thank goodness you caught that, right? So those things are important.
Yeah. Absolutely.
So what else do we have here? So I guess if we want to kind of get into the labs and how there's other things here that I might take into consideration. But when we take a look at patterns, I always kind of think about, I want to ask that question, like, what state is my client in? Is this a person who's in a cell danger or excessive stress physiology, or is this a patient who's in pretty much homeostasis? Like, hey, they feel good, they look really fit and trim, they're not have a lot of complaints. I might say this is a person who's probably closer to homeostasis, so I want to keep that in mind. Or it's a person who's got all kinds of chronic complaints and symptoms. This is probably a person operating from allostasis. And I want to take that into consideration when I look at the labs. So when I take it to labs and I look at my comprehensive panel, the first thing I want to do is look for, does this person have an inflammatory pattern? So what tests might we look at to see if there's a pattern of inflammation or oxidative stress? I'll definitely look at uric acid, right? If uric acid's elevated, that's a flag for me. I talk about ferritin specifically as a marker of oxidative stress, so that's a big flag for me. I'll take a look at fibrinogen, if that's elevated, CRP. I'll take a look at homocysteine. So there's 5. And then probably I'll take a look for a low bilirubin level, because when bilirubin's low, I have to look at their red blood cells because it could be a factor of low red blood cells. But if bilirubin's low, bilirubin can be recycled to be used as an antioxidant. So those are like 6 quick things that if you run them on a blood chemistry panel that you can look at and say, hey, I've got a patient with inflammation or oxidative stress. Now I've got to try and figure out why and where is this stuff coming from. And I know I've got a person who's operating more from allostasis than homeostasis.
And you're anchoring the concept of systemic inflammation because that's really driving a lot of what we see become an eventual pathology. There's a fire smoldering somewhere. You need to know that fire is in existence. So you have kind of a systematic approach of going, okay, now I need to know the decision-making process to get the fire under control.
Yeah, and so it's important to understand, okay, there's inflammatory oxidative process going on here. And so this is a person who's going to be operating from a cell danger perspective. They're not in heal mode. They're not in regeneration mode. So this is where I think sometimes we get frustrated with, if we don't pay attention to the fact that they've got oxidative stress, they've got inflammatory stuff going on. And we're struggling, like, why aren't they healing? Well, because they're not in heal mode. If you read a paper like Navio's his paper a couple times, you start to go, hey, there's phases here. When you're in cell danger perspective, you're not in heal mode. The way I explain it to my clients is, because a lot of my patients are female, so I usually say to them, let's assume that you are you're having a big party tomorrow. You're cooking a whole bunch of food. You're cleaning. You're doing wash, right? You're doing a whole bunch of things at one time. Your child is sitting at your kitchen island. You make them lunch. And meanwhile, you got 4 burners on. You're cooking. You're doing all this stuff. And somebody breaks in and starts attacking your child. What are you going to do? Are you going to continue to cook? And they'll be like, well, no, I'm not going to continue to cook. All right. Are you going to take this stuff, turn the burners off, pack everything up in nice glass Tupperware and put it in the fridge? No. Okay. Are you going to try and slide a load of washing? No. Are you going to try and finish vacuuming? No. Are you going to go take a nap? No. Are you going to try and go have sex? No. I'm like, well, why wouldn't you do anything? It's because none of that's important. Right. Cells operate in one of 2 states. They're either in low stress manufacturing mode, where they're making hormones and peptides and neurotransmitters, making all this great stuff, cell membranes, right? Or they're in cell danger physiology. And when they're in excessive cell stress or danger physiology, manufacturing gets turned down. So that's not important. And cell defense gets turned up. And part of that cell defense mechanism is to release a bunch of inflammatory chemicals, make free radicals to try and A, find and kill the thing, and B, alert the immune system and the surrounding cells that, hey, there's danger going on here, danger. And so that the immune system knows where to come help. And the other cells know, hey, we got to circle the wagons, close the doors, button down the hatches, and get into a protective mode as well. Now, many times you get an infection, you get a bacteria or a virus, and the body does all this stuff. You don't even know this stuff's going on. But when we get this chronic cell stress, cell danger response, that's when we see this more of this shift. And since we kind of on that topic, we've talked about inflammatory markers, the next part of that I'll take a look at is the thyroid panel. Why? Because when a cell is in a low stress homeostatic state and it's in manufacturing mode, what does it need a lot of inside the cell? It needs a lot of T3, the active hormone, because T3 turns on the manufacturing processes. It allows us to make lots of stuff. It drives mitochondrial function. So if you want to have a manufacturing system, you need to have lots of T4 converted to T3 to drive metabolism. So you want to look at the full thyroid panel and see what's going on. A cell that's in stress mode or in danger mode is going to actively downregulate the metabolism of the cell. Why? T3 binds to two different types of receptors in the cell. Keep it simple. Binds to some receptors that turns on the processes, and then T3 binding to other receptors turns processes off. So if I have a cell or tissue in danger mode, or lots of cells and tissues in danger mode, what am I going to see? I'm going to have hypothyroid signs and symptoms. We'll talk about the rest of those on the labs, but I'm going to start to see a decreased conversion of T4 to T3. I'm going to see a lower T3 and start to see a rise in reverse T3. And so we can look at that. If I see total T3 down, free T3 down, reverse T3 up, and then I can also look at the ratios of T3 to reverse T3, free T to reverse T3, and free T3 to free T4. And if I look at those ratios, and those ratios are all low, not only do I have a low T3 state, but my ratios show that I have a low T3 state too. And now I know that I have a cellular or tissue hypothyroid state going on. And now I got to figure out which tissues are impacted by that. So I'll look at the inflammatory markers, then I'll look at the T3, reverse T3, T4, take those things into consideration. And sometimes people would say, what about TSH? Listen, TSH can be all over the place, right? If I have inflammatory stuff going on and it's early on in the phase, I may have a low TSH and low T3. Why? Because inflammation initially is going to upregulate the conversion of T4 to T3 at the hypothalamus. And so that's going to activate my sympathetic nervous system. So I may have a lower TSH hiding this tissue hypothyroidism. Also, as TSH goes lower, I'm going to have reduced conversion of T4 to T3 in the tissues to kind of help that tissue hypothyroid state. So early on, you might have a normal or low TSH. It's not till later that you might see the TSH really start to rise as you're losing function of the gland. But that's another discussion. So we took a look at the rest of the thyroid panel. What else is going on? I want to see, do I have sufficient T4 and free T4? Like I said, thyroid gland still able to make enough T4. Remember, most of the thyroid hormone produced by the thyroid gland is T4. Very small amount of thyroid hormones made by the thyroid gland. Most of the T3 in the body is made by the conversion of T4 to T3 inside the peripheral cells. So if I have a low T3 state, it may not be, the gland can still be functioning, but it's a tissue issue. And I think that's how most things start. Sometimes
a conscious decision by the body to downregulate that conversion, right? So I'm listening
Absolutely.
to you here. We got the overarching pattern of there's a fire, and we want to be able to douse that fire. And if we can't, we lose the reserves of fighters, so to speak. You know, that's kind of like the inability to convert properly. So that fire is driving this process on and on. So from here, we have inflammation, overall metabolic profile, some aspects we can't figure out. Where do we go next?
Well, then I think what you do, once you take a look at what's going on there, you say, okay, I've got an inflammatory process. I've got some tissue hypothyroidism going on. The next thing I want to look at is, do I have thyroid antibodies elevated? Is this process been going on long enough that I'm now getting damage to the thyroid gland? Too often, I think what happens is we see thyroid antibodies. We say, oh, I don't have thyroid antibodies, so I don't have Hashimoto's, so they don't know really what's going on. Listen, if you have sufficient iodine, you're in the US, you probably have sufficient iodine, and you got a thyroid problem, it's thyroiditis typically, and it's immune driven. I don't care if you have antibodies, you don't have antibodies, because oftentimes thyroiditis starts off as a Th1 dominant disorder, then later it becomes a Th2 dominant disorder, and we see more of the antibodies. So, but why do we see the thyroiditis start? My perception of why we often see the thyroiditis start is those cells in danger releasing what we call PAMPs, DAMPs and PAMPs. DAMPs are damage-associated molecular proteins that go out into the bloodstream. Those are pieces of the cells being damaged. They're telling the immune system, hey, I'm the tissue being damaged, come help me. They can also release PAMPs, pathogen-associated molecular particles or peptides or proteins that are pieces of a bacteria or virus that they can throw out there to tell the immune system, hey, this is the thing that's causing the damage, and go find it. So that's part of that cell danger response. But it's also those DAMPs and PAMPs can bind to receptors at the thyroid gland. And when they bind to the receptors, these toll-like receptors on the thyroid gland, it initiates thyroiditis. The thyroid cells actually become immune-like cells, almost create a self-disruption, release inflammatory chemicals, and that's what invites the immune cells, the white blood cells, to come in and create the thyroiditis. So that, to me, makes it sound like, hey, we have an adaptive response more than we have an immune system out of control, which is what most of us learned when we were doing functional medicine, is the immune system's out of control. That's not a good place to have your clients thinking where they are. My immune system is out of control. It's better to think, wow, the physiology is trying to slow down metabolism. We're trying to slow down a whole bunch of cells. We might as well turn it off at the source for now. And now we get the thyroiditis. People get caught up on the antibodies. Take a look at the antibodies, see if there's antibodies there, but the antibodies don't really cause much of the damage to the gland. Thyroglobulin antibodies cause no damage at all, and TPO antibodies cause very little damage at all to the thyroid gland. Most of it's done by those infiltrating white cells. So now I've looked at my inflammatory markers. Now I know I've got tissue hypothyroidism, maybe not glandular damage or destruction to a point yet. Now I want to see what patterns, what tissues are being impacted, or what systems are being impacted by this cell danger adaptive physiology. So one of the first things to take a look at is, do I have an insulin resistance pattern, right? And so we talk about insulin resistance and prediabetes and diabetes like it's too much calories, too little exercise, right? That's the main problem. But in reality, how does cell metabolism work? If I eat more food than I need, what's my body supposed to do? It's supposed to increase my metabolism. As soon as I start storing excess calories in my fat cells, that's supposed to produce leptin. Leptin's supposed to go to my brain. It's supposed to turn on my T3 production. I'm supposed to increase that leptin's supposed to convert T4 to T3. I should have higher metabolism, but that's not what we see. So why would we get insulin resistance in this cell danger mechanism? Well, one of the reasons is, when a cell perceives danger, it's going to wall off the cell. It's going to limit transport of nutrients into the cell. All the glucose transporters need, guess what? T3 to support the transport of glucose into a cell. So, hey, I have cell danger. I downregulate the inner metabolism. I have less T3 in the cell. I decrease the transport of things in there, including insulin-driven transport. So what happens? I get higher fasting glucose. Now my body's like, whoa, we got to get rid of this stuff. And now it's got to make higher amounts of insulin. So now my insulin levels are higher in a fasted state. And the longer that glucose is in the bloodstream, the more that glucose sticks. So I have people, we'll take a look at their fasting glucose, their hemoglobin A1C, and take a look at that fasting insulin. And fasting insulin or C-peptide, whichever you prefer. Fasting insulin's cheaper than a C-peptide, so I often run that more. But that's a great window to what might be telling us that, hey, we've got this cell stress response going on. We've got a decreased glucose transport. We've got a low T3 state. We've got a cell danger response. It's not about calories in, calories out at this point. It's not about too much food and too little activity. This is probably driven by that cell danger response. So where does all that excess stuff go? Into our fat cells to get stored, and our patients get fat. So I'll look for that pattern. You want me to do more?
Yeah, keep going, dude. This is amazing, because not only am I not having to talk very much, this is poetic to me. So keep going. You're in a flow.
So the next place I'll look is at the liver. Like, is the liver being impacted by the cell stress, cell danger response, right? So what can we look at? Is there anything there that we can look at? Well, look at cholesterol, look at LDL. Right? If I've got cholesterol rising in the bloodstream, that's a good indication that liver is not functioning as well as it should. It's also a really good indication that I probably got a lower T3 state. Why? To get cholesterol out of the bloodstream and into the liver, the cholesterol and LDL needs to kind of dock to receptors. And if the cholesterol can't dock to the liver, because those receptors at the liver require, guess what? They require T3. So if I have a low T3 state,
yeah.
Right? If I have a low T3 state, then cholesterol levels are going to be up, and LDL's got to transport it. LDL is going to be up. We get more complex. Every enzyme that regulates cholesterol metabolism is controlled or regulated by, guess what? T3. So all the lipases, all of these things are regulated by T3. So that's a really good sign. Another really good sign is that if they have high triglycerides, elevated VLDL. That also tells me I've got problems with thyroid physiology and I got some problems at the liver, right? If triglycerides are high, VLDL is high, man, I'm stacking up fats. I can't use them. I can't burn things. And so I've got a problem. What's loaded in the liver that really needs thyroid hormone to drive it? You got tons and tons of what? Mitochondria. And so I hear people say all the time, well, I've got, my patient's got mitochondrial problems. Absolutely they do. If they're in cell danger response, their mitochondria is going to
kind of the underpinning of the whole thing, really.
Right. I think that you have a mitochondrial disorder. If you have a excessive cell stress going on, you have a mitochondrial disorder. That's your mitochondria actually downregulate as part of that system. And sometimes people are like, well, why would the mitochondria be downregulated? Wouldn't they be upregulated because there's danger and they need to make more energy? Every time the mitochondria makes energy, remember, you need high oxygen state to burn fat, especially in through that mitochondria. But in a cell stress, cell danger response, one of the things that happens is we stiffen the cell walls. There's decreased oxygen transport into the cell. So now I've got less oxygen for the mitochondria to work. So we've got a more hypoxic state inside the cell. Why is that important? That hypoxic state activates the deactivation of thyroid hormone to help with that low T3 state. But why would this be beneficial? Well, when mitochondria make ATP, the byproduct is oxygen, right? And so if you have, and there's some free radical formation that's occurred. So we get oxidative stress just from the normal exhaust of the mitochondria. But part of the cell danger response is to increase the oxidative stress inside the cell. Why? Because those free radicals are used to kill whatever the threat is, right? So
yeah, your body's down regulating energy production. So whatever is trying to steal from us cannot sustain itself.
Right. So if we're pumping our mitochondria super hard and making a whole bunch of oxidative stress, and we've got the cell making oxidative stress to deal with an organism, that might quickly overwhelm the antioxidants we're able to make, and now we kill the cell, right? We have so much oxidative stress that we damage the cell. The body doesn't want to do that. So one of the cool things is, hey, we've got the threat, we'll wall this thing off, reduce the oxygen, slow down the mitochondria, right? So we're more efficient, but we can't get as much stuff through there. And now we still run the system, but we're not going to kill the cell, right? So that's part of the thing. So I'll look for that liver pattern, look for elevated triglycerides, VLDL, look for elevated cholesterol, LDL. Pretty simple pattern that the liver struggling a bit. And then
do you do any cholesterol particle subtyping? Like look at the small dense LDL stuff, the larger ones?
I don't do that initially as part of a panel. I think early on with most of these people, that's not like the higher priority. I know that some of these people are going to have some of those issues to begin with.
Likely going to be a thing if they're inflamed to begin with.
Right. So do I need to spend the money on that test to see it? I think it's cool to see, but the problem is we've got patients that have limited funds and tests can be expensive. So how can we get the most out of a test? And I think that like a comprehensive blood chemistry panel, you can get a ton out of that if you just look for some of these patterns. So the liver pattern is important to look at, and then go look at indications that, maybe I've got problems with my mitochondria. Look, simple thing, maybe take a look at what creatinine levels look like, right? Wouldn't that be a good indication of, hey, am I making a lot of ATP and do I have a lot of kind of waste from that process? And if they've got low creatinine levels, maybe I don't have very good ATP function. Maybe I'm not making much ATP. And on a general blood test, that would be one of the things I consider. So I've got insulin resistance. I've got fat accumulation. I got low T3 state. I got low creatinine. My mitochondria is probably struggling along as well.
Where do hormones fit in this? Where do like sex hormones fit into this whole process as not only an indicator, but also how do you tease out some of those patterns with all of the above that we've just talked about?
So I don't run generally androgens and estrogens on my initial comprehensive blood chemistry panel because, again, I'm looking at their signs and symptoms. I'm looking at their labs and making this. I assume that somebody has chronic health issues has what I call a multi-system adaptive disorder going on. Okay, MSAD, right? So what does that mean? My patients want to know what's wrong with me. Do I have a thyroid condition? Do I have irritable bowel? I think I have adrenal fatigue. Look. You have a multi-system adaptive disorder. You've got excessive cell stress, all the stress that you're encountering with your environment, your gut, your emotional stress is creating too much stress. Your body's in danger mode. And because of that, multiple systems are getting less energy, less support. And now they're starting to break down a bit and show reduced function. So I always tell my patients, you shouldn't be surprised that your sex hormones aren't regulating well. It's not important when you're in a danger mode. You shouldn't be surprised that your gut's not functioning well when you're in excessive stress mode. If you're being chased by the proverbial tiger, you're not stopping to have a meal. You're not stopping to have sex. You're not stopping to sleep. So those are things that I assume there's going to be a problem. But if I'm looking at that thyroid panel, I might use that T3 uptake and what that value is to assume like, hey, we've got some excessive estrogen issues here because as sex hormone binding globulin goes up, as estrogen goes, sex hormone binding globulin goes up, I may have a T3 uptake that's reduced. I may have lower free hormones, and that may be an issue. So I'll look at those free hormones from that perspective. If I have the opposite going on where I have higher androgens, lower estrogens, I may see a higher T3 uptake and higher free hormones. So from that perspective, that's how I would look at that.
And I believe we've gathered almost all the different categories. What's left in the process of assessment?
I would definitely look at the iron pattern. So iron regulation to me is really important. It ties into the cell danger response. So many people think they're anemic because their serum iron's low, their iron saturation's low. And a lot of times they're not getting ferritin tested, or they're getting ferritin tested and people are saying, hey, your ferritin needs to be around 90 because it's a sign of iron storage. I don't think that's the case for most people. Matter of fact, if you look at the most recent COVID studies, especially in women, they're saying that a ferritin over 90 is a good indicator of COVID. So if you look at the work of Douglas Kell and others, they believe that ferritin is a tissue protein, not a serum protein. So it should not be in the bloodstream at very high levels. If it's elevated in the serum, then it's an indication of cell damage or an inflammatory, or it's upregulated production and release from the liver due to cell stress, due to bacteria, infections. And the ferritin is out in scavenger mode to try and help scavenge up iron. Why would the body do that? When there's inflammation, where there's organisms, the body wants to sequester the iron, wants to take iron out of the bloodstream and push it into the tissues. Why? Because the organisms use the iron. So when we see low iron and ferritin levels, so if you saw low iron, to me, I'm thinking, whoa, we got some type of cell stress mechanism going on. If ferritin's elevated, I know that really kind of confirms it there. They have an anemia of inflammation or chronic disease, not iron deficiency anemia. It's really hard, in my opinion, to have an iron deficiency anemia because we don't have a great way of getting rid of iron. Unless somebody's bleeding out, they're probably not truly iron deficient. But I want to look at that iron pattern. And oftentimes you'll see one of two things. You'll either see a really high serum iron or a really low serum iron if it's out of range. So the high serum iron, I'll automatically go to see if they're taking vitamin D. And if they are taking vitamin D because they have chronic low vitamin D, I'll get them off the vitamin D. So if you take high dose vitamin D, it can have an impact on your vitamin A absorption. You need vitamin A to get iron out of the bloodstream into the cells and tissues and for iron to be used appropriately. So that's one pattern you'll typically see, but typically with this inflammatory mechanism, you'll see more of a low iron saturation, and typically a high ferritin level. Now, if you see low iron, low iron saturation, total iron binding capacity is high, and low ferritin, you have to run one test to confirm or differentiate whether it's iron deficiency anemia or anemia of inflammation before you even consider giving them iron. And that is your soluble transferrin receptor test. So you run that. If soluble transferrin receptor is high, that means there's probably iron deficiency because, hey, there's cells now making a lot of these receptors to try and catch as much iron as they can. If it's normal or low, the cells have enough iron. They don't want any more. You don't need to give them iron because that could actually increase oxidative stress, feed the bacteria, feed the organisms, create more problems. The body's trying to, what you're seeing is an adaptive response, not dysfunction. So that's one of the patterns I'll look at. I'll look at liver and gallbladder pattern. Definitely look for check out your bilirubin. If it's under 5, it could be a sign of oxidative stress, but check your red blood cells, make sure the patient's not anemic. Second thing to consider is if that bilirubin's above 8, consider we're starting to get some biliary congestion. Liver enzymes, everybody talks about AST, ALT, that they may be indicators. To be honest, they're not early indicators. I look for bilirubin, signs and symptoms and bilirubin as indicators first. Maybe also take a look at some of your lipid markers. If they're low, especially triglycerides really low and bilirubin's high, another good indication that I may not have good biophysiology. How does that tie in? Cell stress response, cell danger response. You need thyroid hormone to make bile and have appropriate biophysiology. So again, cell metabolism is reduced. Then I'll look for adrenal pattern. Is the adrenal gland does it look like I might have a hypoadrenal or hyperadrenal pattern going on? And I like a test like the Dutch test, but on the blood panel, you can simply look at your sodium potassium ratio and see what that is. Right. So if your sodium levels are low and your potassium's high, it's a good indication that you've got some type of low adrenal function going on, and something to consider. Also, remember, if cholesterol's high in the bloodstream and you have a low T3 state and you think you have mitochondrial problems, you're probably going to have low cortisol. Why? Because to make cortisol or DHEA or any of your androgens, you need to bring cholesterol out of the bloodstream, into the cell, into the mitochondria, because that's where all the action happens. So
I'm going to go out on a limb and guess that might have something to do with T3 as well.
It does, right? So we start to, when you start to look at these labs, you start to go, man, there's a lot I can learn here. You start to take a look at, you look at that renal pattern. Is what's going on with is my BUN high or low? Does that indicate I have a renal issue? What's my creatinine? Is creatinine high? I have a renal issue. Is my GFR low? I got a renal issue. So there's lots of patterns that we can look at to start to say, hey, these are the tissues that are really struggling. And I always look at it from that lens of, do I have a low T3 state? Yes, I do. I need to consider, do I have a cell stress, cell danger response? But I want to look at what tissues are struggling, because that helps me understand which tissues I'm going to have to put time and attention to and help them maybe support and rehab. What's interesting is when you start looking at the stress factors and eliminating those stressors, oftentimes you don't have to do anything with the labs. You start reducing the stressors, removing those, and the body starts to come back online, because it's not broken physiology. Often it's adaptive physiology. And so you run your panel after a period of time. You say, okay, we made a few changes. Let's see what happened. Hey, look, these are all starting to get better. Why? Reduce the stress, the danger physiology goes away. Cells start to kick back into growth and regeneration mode.
That's an incredible insight, because we can get too fixated on numbers and labs and forget we're treating a person that has a way of perceiving the world and has, things that may be easy to adopt and harder to adopt. And it's a beautiful segue. So it's like, and I don't want to ask this question poorly, but it's the only way I can ask it. So let's say you see a lab that you don't like, a bad lab, right? What are your immediate next steps in terms of considerations for treating the person? Is it diet first? Is it lifestyle? Is it supplementation? Is it circadian rhythm? Is it sleep hygiene? Or do you have every person is different, so I have to approach this exactly as I think they need the greatest level of support here, or the least level of support there?
I look in, Kelly and I talk about in the book, we kind of break it down to fitness factors: their dietary fitness, their physical fitness, their emotional fitness, their respiratory fitness, their sleep fitness, their metabolic fitness, their habitual fitness. So we look at all these different categories almost immediately out of the blocks. I'm going to talk to somebody about what's going on with their diet. I'm not part of the diet wars, like which one's better or worse. But I think if we all just did a whole food diet for the most part, that's a great place to start. So clean up the diet. That's an easy thing for almost everybody to do. So give some instruction there. Often, if I see a GI pattern on the blood work, elevated alk phos, multiple malabsorption markers, they have signs and symptoms, I may take a look at a GI tract testing to see what's going on. But initially, I'm looking at, let's get the dietary stuff changed. Start working on the gut. I'm a big gut advocate because everything has to go in through the GI tract. Everything pretty much has to go out. So you can dump all these supplements in there, but if you don't start making some changes there, you can't detoxify really well into a vessel that could just wind up resorbing stuff. So that becomes a big part. Along the way, I'm talking to them about things that they really don't want to change. One of those, respiratory fitness, is so, so important to health and well-being. So I have patients do 3 simple tests, right? A simple breath test: left hand on chest, right hand on belly. Take a deep breath in. Which way does your belly go? In, fail. You're going to need to do some breathing exercise. Test 2.
The chest breathing, the shoulders elevate and the neck gets tight.
And I explained to them why, but these are 3 simple tests everybody can have their clients do, right? Second one is, what's your respiratory rate, right? How many breaths in a minute? I know the average is 16 to 25 breaths per minute, but what's research say is optimal? Optimal is like 5 to 6 breaths per minute, right? And we're telling people,
no one hits those numbers anymore.
So,
no one.
No, they don't. I do have a client. I have an 84-year-old guy. He's an outdoorsman, hikes all the time. His blood, his pulse is like 46. His respiration's like 6, right? But he's like the oddball, but he's 80 some, right? But
it comes from a generation that they don't make humans like that anymore.
But this is a problem, right? If you breathe too often and you breathe inappropriately, and you know this with your athletes, what happens? You don't get good carbon dioxide oxygen exchange. Everybody thinks, oh, my oxygen saturation is 99%. Well, whoop-de-doo. If your oxygen saturation is 99%, but you don't have the carbon dioxide in the system to allow the blood cells to give up the oxygen, they're going to hold on to the oxygen. Then you can't get oxygen to the tissues. If you don't get oxygen to the tissues, now you have tissue hypoxia. What does that do? That activates the cell danger response. When do people do it the most? At night, when they're sleeping. Everybody says they breathe through their nose when they're sleeping, and they're all don't tell the truth, mostly because they don't know. So I'll have them do the simple breath test. How many respirations in a minute? The third one is a controlled breath hold time test. Blow all the air out. How long can you hold your breath before you get uncomfortable? Not how long you can do it before you pass out, but how long before you get uncomfortable. Muscles in the side of your neck pump, vessels pump out. You feel like you got to swallow. You just get a little anxious. That number optimally should be up and around the 40s. If you're a lot of my clients are coming in, they're under 10, they're under 15, they're under 20. They've got to work on their breathing. Why is it so important? Because if you don't breathe well and you have inflammation and you lay down at night, what happens? The mucous membranes swell. Now your nasal passages get clogged, and you have a nasal cycle. So now you really can get congested. And now you open your mouth to breathe, because when you breathe through your nose, that's your filtration system. Everybody wants to buy all this expensive filtration for their house. How about breathe through your nose? That's the best filtration system you have. Plus you get nitric oxide production, which creates vasodilation, really important. But once you start breathing through your mouth, now you've got other problems. You're not getting that good carbon dioxide CO2 exchange. You're getting hypoxic. That's going to keep activating the sympathetic nervous system. It's going to downregulate your thyroid physiology. Your patients are going to be putting on weight. They're going to have more inflammation, and they're going to be getting up to pee at night on a regular basis, thinking they're drinking too much fluid or something else, or they're just getting old, or my bladder's getting weak. When in reality, what's happening is they're not getting good carbon dioxide oxygen exchange. They're not making vasopressin. Now they're producing more urine instead of resorbing those fluids. And now they're waking up. Every time they come out of that sleep cycle from deep sleep into light sleep, they're feeling the pressure of their bladder. They got to get up. Sleep's disrupted. So important. Nobody wants to work on it. So they got to do breathing exercises. They got to tape their mouth shut, maybe tape their nose open. But those are things they got to work on. I talk to them about their habits, their behaviors. We talk about how to have good sleep habits, but you got to work on every one of those fitness factors. Why? Because they're only going to be as healthy as the weakest link.
It's interesting because patterns really are kind of underpinning this whole thing. You look at one thing as a CDR, and it's literally a cascade of effects that stem from a source of origin. And to get back there, it's not one thing. It's not one supplement. It's not one diet. It's not one adoption of a new habit. It's a confluence of variables that put the body in a state to self-heal. It's not the person. I mean, you're incredible at what you do, but you don't heal that person. That person's body heals themselves. You just help get the things out of the way that are blocking the healing and keeping that person in the healing cycle, if you will. They're not ever transcending, staying in the cycle.
Yeah. And I think what's important for us to make sure our patients understand is, and how I explain to my patients, I'm like, think of the stress, right? Because they're thinking, oh, it's just emotional, or it's just this bacteria. But I say, listen, think about like two cinder blocks in a piece of like a 2x6 going across, right? And as we go through life, think about like just adding 5-pound weights to the board. That's the stress we put on our system. And sometimes we put the 5-pound weight on, and sometimes we take it off. But if we don't take them off and we just keep stacking that weight on there, we can tolerate quite a bit before we're into danger mode. But if that capacity of that board's like 100 pounds and I got 100 pounds on it and I add just one more pound, what happens to the board? It breaks. And we could say, well, it wasn't a big stress that might have triggered it, right? But it didn't need to be. It only needed to be a small stress because you were already at threshold, and now you're into danger physiology. For that board, people say, well, I gave up gluten and I didn't get better. Well, look, once the board broke, taking the 1-pound weight off doesn't fix it. Right? Now I've got to take all the weight off, almost all the weights off, and then rebuild the board. I've got to reinforce it, nail and screw another board to it. So I've got a bigger, stronger board. But the beauty of that is if I reduce a lot more stress than I think I have to do to get my patient out of danger mode, now I support the recovery of the tissues. Now undergoing that stress might have actually made them stronger. Just like I reinforced the board, that board can now hold more than 100 pounds. Now that person may be more resilient down the line. Isn't that what we do with physical fitness, right? I want to work out my muscles, right? Absolutely.
Definition of hormesis, where you're making that person more able and capable to tolerate the stresses of being them, whatever that is. And, I always like to say that the body loses its bandwidth of compensation once the symptom is manifested. But that could have been 5 years before the body finally waved the white flag and went, all right, well, I'm going to bring attention to this because I can't hide this from you anymore.
Yep. And we try to ignore stuff, put it off to the side, work around it. And the body's pretty good at doing it. It's really good sometimes, we think, at taking those emotional stressors and just putting them back there. And we just don't
them down.
Yeah.
And you watch a movie and all of a sudden you start crying like a bit. Well, maybe that doesn't happen to you, but
it's one of those things that really, especially for me, when I'm doing a lot of the things and dealing with all these fitness factors that we talk about in the book, and the person struggling, the emotional component is not my strong suit. So that's where I'm like, hey, we got to have you work with somebody. I refer a lot of my clients to somebody who does the MAP method, which is a way to look at the amygdala and the limbic system and try and do some retraining of that system to change the perception of what they're perceiving. And that's been really helpful too. So every component kind of needs to be looked at to try and bring them back to health. It's not just slapping supplements at people can help them get there. But if you don't deal with their respiration, their sleep, their physical fitness, their diet, their emotional stress, what their habits are, I don't think you're going to get them healthy for a long period of time. And that's not my goal. I know it's not your goal. We want to try and get them out of this danger physiology, get them into recovery mode, and then sustain a higher state of health versus managing chronic illness, chronic symptoms, and chronic disease.
Yeah, you want to use a true holistic perspective. And I really appreciate not only mentioning that and bringing it back to that focus at the end, but everything that you gave us up until this point. I'm going to listen to this multiple times over and over again because some of those patterns were incredible. And, we could go for another hour. I know we could, but we don't have it. And I want to be respectful of your time and the time of everyone who's listening. So, if we take everything we learned today and we go, okay, Eric, this is incredible. Where can I start focusing my attention and efforts at getting better and more proficient with reading blood labs? Where would you suggest people start to get more comfortable rather than being too intimidated that they can't do what you can with a pattern recognition right now?
Well, I think the starting point is you got to run them and start looking for them. There are some people there that are, I think, really doing a good job. I'm hoping that we at Master Supplements will take on some of this role of helping people understand what's going on. In the book I wrote with Dr. Kelly, I kind of talk about some of these things, these patterns in the Thyroid Debacle, and to talk about the fitness factors and what to work on. But I'll tell you, one of the, obviously there's some functional medicine courses, but one of the people I think who does a really good job, kind of goes against the grain a little bit, is Brian Walsh.
I love Brian Walsh. He's so good at his understanding of physiology. The man can write on a whiteboard backwards as he's describing something to you, and he can draw it in real time.
Yeah, so I know Brian does a really good job of not just following the status quo of what everybody says, but trying to help you understand the mechanism. So I would recommend Brian's course, some of his stuff. I've done some of his stuff. I know he's got a ton of stuff out there, but he's a great resource to kind of help somebody look at labs a little bit differently, especially if you're not really sure what to go. But I those are things that I even do with I do have some docs call in, and I'll just sit with that. I mentor them through looking at labs, go over them. What pattern do you see? Here's what I see. Here's the strategy I would use. And I've got a number of docs that I do that for and help them with. So if somebody's interested in that type of help, by all means, they can reach out to me, my email, and say, hey, I need some help, and do that.
Thank you. And it comes back to this, we're all trying to support each other, no matter what your specific specialty is. Everyone can learn something from someone else that they may not be necessarily applying. And if you get the understanding and then provide the right context, it can really change the game for your practice, because we're all in the business of getting people better. And that's really what we're trying to do. So I think this warrants another one. I'm totally going to put you on the spot and ask you in front of everyone. Can we have you back a little bit later down the line to do a part 2?
Yeah, absolutely.
I think it warrants that. And I like that you said, within the fold of Master Supplements, US Enzymes, that's why we're doing these master classes. It's letting you live in your genius and express that to the world so people can latch onto that and become more inspired to want to step up their game. Because one person with a busy practice can help hundreds of people, who can then go out and help thousands of people by teaching them what they've learned along the way. So, Dr. Eric, thank you so much. We're a little bit over on time. Is there anything that you kind of wanted to touch on before you finish? I know you have a new book coming out. Sulforaxym is the brainchild, or I should say the baby that you've helped us create. It's a product that we're actually featuring this month that was totally happenstance and cool, but I'll let you kind of end it off with what you want to talk about.
Yeah, well, hey, if you want to learn more about what we're talking about, obviously pick up a copy of the Thyroid Debacle, the book with Kelly Halderman. And in that book, we talk about, hey, why the medical model is kind of struggling. We talk about the new way to look at kind of cell physiology and thyroid physiology through this lens of the cell danger response. And then part 3 of the book is here's all the things that as the patients can do to help them get better. But it's really even for the practitioners going like, I don't even know where to start with these things, simple things that you can give your patients to do that can be helpful. And I think it's really important. I think you would agree with this. I talk through the lens of thyroid physiology. A lot of people think about or say, oh, you're the thyroid expert. Listen, I'm not an expert in anything. I think I'm a pretty good generalist. If you're an expert in one thing, you're probably not very good physician because you don't understand all the other stuff. So I don't try and specialize in anything. I try and be a really, really good generalist. So I know how all these systems try to integrate versus I only know about the thyroid physiology. I'm just trying to normalize T3 and T4. I would say for people who are looking at inflammation and how do I manage inflammation, I'm a huge fan of sulforaphane. Why? Sulforaphane is super absorbable, gets to the brain quickly, doesn't get toxic in the system, and it's one of the best food activators of something called your NRF2 pathway, which is your body's major antioxidant, anti-inflammatory, and detoxifying system or enzyme. So with one thing, you can do a whole bunch of things. You don't turn on one pathway, you turn on 200 different kind of pathways to help support those three things. So I'm a big fan of sulforaphane. And now that we have sulforaphane with actual sulforazyme with actual sulforaphane, I'm even more excited, and I use it regularly with my clients. So those are the two big things. Hopefully, maybe we'll have another product out here in the next year. But I keep giving Jeff some more ideas of things that we need and we can put out. But those are the two biggies. So look for the book. If you do read the book, please, please, please go to Amazon and give us an honest review on Amazon, because that is always a good thing for people like me who are selling books. I will have a Thyroid Debacle course with Kelly we're going to put out probably in the next year of how to think about everything we talk about in the book.
Well, Kelly is our next guest in August, so it's
Perfect.
literally the perfect timing for all of this. So I changed my original request. I want both of you to sign my book because I'm high maintenance like that. Eric, this was awesome. I'm going to listen to this over and over again because I did learn a few things that I want to look to start applying with my athletes. I think this is an incredible aspect and an area of opportunity because you can take this information and apply it under so many different contexts. So I want to thank you for your time, for your wisdom, your insights, your brilliance, all this amazing stuff. And we'll see you sooner than later.
Awesome. Thanks for having me on. As always, have a great life. Everybody be good and help inspire others.